Thank you, Dr. Fonkum. Thank you for inviting me to speak, and it's a pleasure to be here today. I did put my email here. If anyone has any questions, I know there'll be time for discussion, but certainly feel free to reach out to me at any point. So let's see here. Here are my disclosures. So today I am going to start by talking about the role of iron and how it is a critical driver of malignant processes in general. And it's important to understand this concept. And once we cover that, we'll talk about the role of gallium multilate in the treatment of malignant brain tumors. And then I will give some updates on the phase 1 clinical trial that we have here at the Medical College of Wisconsin. This is also another overview. It does seem like I'm talking about 3 different topics, but I promise you by the end, you'll understand how all of these topics relate and why gallium multilate is an interesting new approach to treatment that we are exploring. So I certainly don't need to spend much time on glioblastoma with this audience. I think we all recognize the aggressive nature of this most common primary malignant brain tumor. It represents about 1% of all cancers, but it is over 3% of all cancer-related deaths. The classification system was created by Bailey and Cushing about 100 years ago. And the pathologic hallmark features of glioblastoma, as we are aware, is mitoses, endothelial proliferation, and then this pseudopalisading necrosis. And for those who haven't looked at histology in a while, I want you to sort of remember this pattern. When we look at the past 2 decades, there's been 2 instrumental trials that have looked at improving progression-free survival as well as overall survival. And certainly the addition of temozolomide to radiation, followed by maintenance temozolomide, we saw improvement in overall survivals to about 15 months. About a decade later, there was the clinical trial that looked at tumor treatment fields when added to the maintenance phase of temozolomide. And that also improved survival to about 21 months. And so the standard of care at this point is really maximal safe resection, followed by radiation with concurrent temozolomide, and then adjuvant temozolomide and tumor treatment fields. I recognize tumor treatment fields is not available worldwide, but it is something that we consider as part of our standard of care here in the United States. Other than these 2 instrumental clinical trials, there haven't been significant advances. And I think we all would agree that overall survival around 2 years, we have a lot of room to improve. I'm going to shift gears just a little bit and talk about chemistry. We've all had some sort of training with chemistry. Whether we have chosen to forget about it might be a different point. So allow me the chance to refresh your memory. I think most of us recognize iron is one of the most important elements in the human body and is essential for all cellular processes. It's a very tightly regulated element, and we all recognize, if the body does not have enough iron, we develop an iron deficiency anemia. And if there's too much iron, patients are diagnosed often with hemochromatosis. So as a refresher, we can look at this cartoon here on the left, and iron binds to transferrin in circulation, and it's brought into the cell through transferrin receptors. Once in the cell, it is stored in iron pools and then participates in numerous iron-dependent processes, including in the mitochondria. It also is bound to ribonucleotide reductase, which is critical for DNA synthesis. And as with all systems, when you have an influx, you also need an efflux system. And that's mainly done through ferropoietin. So to simplify this cartoon, you have iron importers, you have iron exporters, and you have this tightly regulated iron pool. So as I mentioned, iron is essential for all cellular processes, and this includes cancer. And there's been many researchers who have looked at a wide variety of malignancies. This cartoon depicts breast cancer. And what they have shown is that cancers, because they are a rapidly growing and dividing cell, they will actually increase the amount of iron import and decrease the amount of iron export. And so essentially you're creating this increase in this iron pool to fuel all these iron dependent processes. And in fact, the more aggressive the cancer biology, the higher these iron stores are. And so as neuro-oncologists, we have to ask the question, or at least I would ask the question is, do we see the same thing in glioblastoma? And it is indeed true. So remember that pseudopalisading necrosis that I had shown a couple of slides ago. This is the histology, but staining for transferrin receptor type 1. And then you can see that these glioblastoma cells have increased staining of transferrin receptor, but not as much as the surrounding normal brain tissue. We also have looked at the grading of the brain tumors, and indeed, the higher the grade of the astrocytoma, the higher the expression of transferrin receptors. So glioblastoma and astrocytomas in general also are dependent upon the iron biology. So iron plays an important role in the brain microenvironment, and we know this because of the brain vascular endothelial cells. These cells express transferrin receptors, but this is unlike the endothelial cells that are outside of the brain, which do not have transferrin receptors as depicted in this cartoon. So we have performed our own iron or immunohistochemistry staining in the brain, which confirms that this is indeed the case. You can see here these endothelial cells staining for the transferrin receptor. We also validated using tissue from our human glioblastoma tissue bank. And you can see here how the glioblastoma cells stain more heavily for the transferrin receptor, but the surrounding glial cells do not have those transferrin receptors. What this creates is the perfect environment for this tumor to thrive. So you have this tumor that is seeking more iron, and you have an environment rich in iron due to this brain vascular endothelial cells. We looked at other iron biomarkers as well, and we saw the same thing. We saw increased expression of ribonucleotide reductase subunit in glioblastomas compared to normal brain. We also looked at H-ferritin and L-ferritin, which are just two different isoforms of ferritin. And so the question becomes, can this mechanism somehow be targeted in the treatment of glioblastoma? This leads us to the periodic table, which maybe we haven't looked at in recent years, but here is iron. And gallium, which is our element of interest, is located just down this row. And just to remind everyone of the very basic principles of the periodic table, elements that are in the same row share similar physical properties, versus elements that are in the same column share similar reactive properties. So when we look at iron and gallium, that indeed holds true. Both are electrically charged 3+, but more importantly, both of them bind to transferrin, ferritin, and lactoferritin, and both are incorporated into cells through the transferrin receptor. But there's one major difference between gallium and iron, and that is that gallium does not participate in those redox reactions. Because it's in a different column, it does not have that reactive property. So the use of gallium is not new to the field of medicine. It actually was first utilized in the 1950s as a diagnostic tool through radioactive gallium scans. And these scans are still performed today around the world. This is a radioactive gallium scan or a gallium-67 scan of a patient with lymphoma. And you can see that there's multiple sites of disease. Once it was recognized that cancers and malignancies seem to uptake gallium, it became also a tool to monitor therapeutic response. And so this is a patient who has intracranial lymphoma, probably a primary CNS lymphoma, before treatment. And after the patient received radiation, the tumor essentially melted away. It then moved into an actual therapeutic use and is commonly used or can be used for hypercalcemia of malignancy. I'm not going to talk about that today. I did find it interesting in that it is also being used in the antimicrobial world. So antimicrobial resistance is a very hot topic. And so there's a molecule that is called galbofloxacin. And essentially, this is ciprofloxacin with a gallium molecule attached to it. And this has been studied in bacteria that are ciprofloxacin resistant. But when they are exposed to galbofloxacin, it actually is incorporated into the cell and is actually reduces the bacterial growth. And it's probably that same mechanism. You know, bacteria are very metabolically active and replicating, and it probably also plays off of that need for iron. And the bacteria sees the gallium, thinks it's iron, and incorporates it into the cell. So this might be a novel way that researchers are looking to overcome antimicrobial resistance. But of course, our main focus today is on its anti-neoplastic activity. And so we'll start to talk about that. The first anti-neoplastic gallium agent was actually gallium nitrate. So this was studied in several phase 2 clinical trials of solid organ tumors. This did not include brain tumors. And it had particular efficacy in bladder and non-Hodgkin's lymphoma. And these are all patients with really advanced disease. And several of these patients had significant responses. It was determined to be very safe. There was no myelosuppression. I think one would be concerned that since we're affecting iron, you know, would patients become anemic, and there was no significant anemia. The challenge with gallium nitrate is that it's an IV infusion, and it's a continuous infusion that's given over 5 to 7 days. And so it just became cumbersome and not practical when managing patients with cancer. Gallium nitrate was studied around the time that there was a sort of a major shift in management of cancer, and started looking at, you know, development of targeted agents. And so gallium nitrate really fell to the wayside. The next gallium compound that was developed, and much has to do with the work done by Larry Bernstein, is gallium multilate. So this is basically, it's gallium with 3 sugar molecules attached to it. And this is an oral formulation. And it's hypothesized that gallium multilate is actually absorbed in the small intestines. And that's because it's very similar. If you look at iron Multil, which is used to treat iron deficiency anemia, it's very similar in its shape and chemical structure. And we know that iron Multil binds the apical transporter DMT1 in the small intestines. So again, it's hypothesized that gallium multilate is perhaps absorbed that way. Gallium multilate has been studied in other malignancies. There was a preliminary phase 1 clinical trial with patients with advanced solid organ cancers that were refractory to treatments. In this study, oral gallium multilate started at 50 milligrams per day and was titrated up to 500 milligrams per day. It was found that it was generally very well tolerated. You can see that there was no significant toxicities. And when we look at the adverse events, again, no significant hematological malignancies as well. But again, this was around the time that other targeted agents were coming to market, and the exploration of gallium multilate for other systemic malignancies really did not take off. However, we became interested in gallium multilate in the use of treating glioblastomas. And this is really where the journey of gallium multilate starts at the Medical College of Wisconsin. So we took gallium multilate and started looking at GBM cells in culture. And we took the D54 and the U87 cell line, and we saw that when exposed to gallium multilate, there was significant reduction in the cell growth across all cell lines. We also looked at glioblastoma stem cells in 3D culture. And here is our control, and here is a representative of the stem cells when exposed to gallium multilate. And you can see at 72 hours, there is a significant reduction in that growth rate. We then shifted to the animal model and actually would implant the U87 cell line in the rat brain. An MRI would be performed about a week later to confirm that the tumor has actually taken. And then we began treatments. Now, initially, we administered the gallium multilate IV, but then eventually figured out a way to train the animal on how to take gallium orally. And so we had our control population, and we had our group of animals that received gallium multilate. We would do periodic MRI of the brain, and then harvest and look at the pathology. And here are some examples of what we saw. So this here is our control subject, which is a male. This is the MRI without contrast, MRI with contrast. This scan here is, we call it delta T1, so it's just basically the subtraction. It helps highlight the amount of contrast enhancement. And then this bottom scan here is looking at MR perfusion, looking at the vasculature associated with this tumor. So this is our control subject on day 28. Here is an animal subject that was treated with gallium multilate. And you can see that there's a small amount of tumor contrast, but significantly reduced compared to the control. And it's not until day 62 that this animal receiving gallium multilate has a tumor volume similar to the control. We saw the same in our female animal population. Here is our control subject. This is the subject treated with gallium multilate, very small amount of tumor. And it wasn't until day 70 that we had comparable tumors in this animal. And when we look at all the animals together, we saw this across the board, that animals that received gallium multilate had significant reduction in the growth rate of their tumor. And also animals that received gallium multilate lived longer. And this is, for anyone that does work with animals, this is a pretty significant extension in life with this treatment. Like so many times, we always have that one token patient that seems to do exceptionally well. And we saw the same thing with one of our animal subjects. So this was an animal that on day 43 had this MRI that it appears to be a fairly sizable tumor. What was unusual was this animal was behaving normal. There was no sign of neurologic dysfunction. It was eating appropriately. It was gaining weight. And because it looked healthy, we decided to continue to follow this animal. And 1 week later, you can see that the tumor was no longer present. And so we actually looked at things under the microscope, and histologically, there was no evidence of tumor cells at all. So this was pretty exciting for us. We felt with the preclinical work and the response that we were seeing, the next logical step would be to take it to the bedside. And so this is where we're at, where we opened the phase 1 clinical trial of gallium multilate for recurrent glioblastoma patients. We opened about a year and a half ago. This is a very standard phase 1 trial looking to identify what is the maximum tolerated dose and what dose would be recommended for phase 2. Of course, we're looking at safety and tolerability. And we're also looking to see if there's any evidence of anti-tumoral activity that, of course, we're not powered to do progression-free survival or overall survival statistics, but we would like to see some sort of activity. We decided to start at the 500 milligrams per day based on the previous preliminary phase 1 study done in other solid organ tumors, with the target dose escalation to 1,500 milligrams per day. This is the actual medication that's encapsulated. We have patients take it on an empty stomach, just because any food interactions with gallium multilate has not been formally studied. The inclusion and exclusion criteria, we left quite broad. Patients had to have had a histologic diagnosis of a GBM grade 4, or they could have been a molecular GBM based on the recent WHO classification updates. They had to have received radiation and temozolomide, but there was no maximum limit as to the number of treatments they received previously. And then they had to have had measurable disease on their MRI or pathologic confirmation of recurrence of their disease. So this is where we're at. 16 patients enrolled. 14 patients are considered evaluable, meaning that they've completed at least 2 cycles. 10 are male, which is consistent with what we see in the general glioblastoma population. 5 of the patients were MGMT methylated. All of these patients are IDH wild type, again, consistent with the glioblastoma diagnosis. And we've completed all 3 dose levels. And so to date, there's been no dose-limiting toxicities. We have not had a patient stop treatment because of side effects. There's also been no laboratory toxicities. We do see a decrease in the hemoglobin, but none of these patients have been symptomatic. None have required a transfusion. And as expected, this is a microcytic anemia, and we do see a downtrend in the MCV. Just to note, there's no evidence of hypocalcemia, low magnesium, or renal impairment, which are some of the side effects that we're seeing with gallium nitrate. So gallium nitrate and gallium multilate are 2 different compounds. Of interest, 3 patients experienced a progression-free survival greater than 180 days. And keep in mind that, median progression-free survival after first recurrence is on the order of 1.5 to 6 months. And then we do have 1 patient who has been on treatment for over a year and is doing well. So no significant laboratory toxicities, but what are patients reporting? I had to include this quote because it just really speaks to what I see in clinic. I had a patient who actually wrote to us and said, "I don't feel sick. I'm worried that I don't feel sick. My husband is worried because I don't look sick. I don't look like a cancer patient." And so we had to smile because it just points to the fact of how well patients tolerate this. So currently, because we feel we haven't reached the maximum tolerated dose, we actually amended our protocol with 2 additional dose levels. And we're currently enrolling at 2,000 milligrams per day. Correlative studies are ongoing, looking at blood levels of gallium as well as all the iron biomarkers. We also have a number of patients who had surgery just prior to enrolling in the gallium multilate trial and then had reduced surgery after. And so we're looking at the tissue staining for transferrin and ferritin and other iron biomarkers to see if gallium multilate somehow changed that, or if there is something histologically that would predict which patients are to be better responders. And then, of course, just based on the results we're seeing, based on excellent tolerability, we have current ongoing plans for a subsequent phase 2 clinical trial. So in conclusion, glioblastoma, we know it remains an aggressive, incurable disease. Glioblastoma cells definitely have some alterations in iron regulation, which increase the iron stores and fuels additional cellular growth. Gallium mimics the iron, disrupting this iron metabolism and blocking the growth of additional cancer cells. In gallium multilate, definitely shows promise in the preclinical animal models and as well as the phase 1 clinical trial. So I have to thank our sponsors, IQAI, the Frederick Foundation, as well as the Musella Foundation. And I also have to acknowledge 2 of our patient organizations. These are organizations run by our patients and their families, Strain for the Brain and Chasing Chad. They helped fund the initial preclinical work that took this really from bench to bedside. And lastly, I have to acknowledge my team. This is not the sole work of me. Anyone who does research knows that we have an army of people behind us, but a special acknowledgement to Dr. Chris Tambar, who spent his entire career researching gallium multilate, and then Dr. Kathleen Schmenda and Dr. Mona El-Ghazawi for the preclinical work that was done with gallium multilate. So thank you for your attention.